Thank you. My name is Shama. I am a paediatric ST2. I'll be presenting our quality improvement project, which is based on looking at paediatric outpatient referrals from primary care based at Milton Keynes Hospital. So a bit of background to the project. Over the last couple of years, the total number of outpatient referrals into our general PEDS clinics have been increasing at about a rate of 12% every year. And if you look at the table below, we can actually see that GP referrals do constitute quite a large proportion of the total number of referrals. So we started to think about the implications that this has, whether that's financial for both primary and secondary care, workload, and more importantly on the patient journey, having their care between primary and secondary care. So we wanted to look at how many of these children perhaps didn't need to be referred, why are all of these children being referred, and whether there was anything that we can do about it. So the primary aims of our project were to identify the top 5 common reasons for referral and how we can work with our local CCG and GP colleagues to help manage more of these children in primary care. A couple of secondary aims included identifying the children who were discharged after their first outpatient appointment and to see whether these referrals could have been avoided in the first place, identify which GP practices had the highest and lowest number of referrals, and developing a resource for GPs for the 5 most common referral conditions so that they can manage them more locally, and also scoping the possibility of outreach clinics in the community. So what we did is we collected data retrospectively from 100 first outpatient appointments that were seen between August and September of last year. We looked at each patient's GP referral letter and then the subsequent clinic letter through an electronic database, and then inputted all of our data into a spreadsheet, including patient details, GP referral details, which also looked at the reason for referral, whether they had any relevant past medical history, and whether there were any prior investigations or interventions that had been done before they were referred. And then lastly, paediatric review details, so the impression and management plan once they were seen in the outpatient appointment. So the brief look at the results. So we identified 100 cases and the median age was 5.5 years. There was a 50-50 male to female sex ratio. Median time from referral to assessment was 63 days. 68% cases were followed up and 32% were discharged. So if we look into a bit more detail at those who were discharged, we can see that actually 12 received advice and reassurance only, whereas the rest of them, although they weren't offered another paediatric appointment, they did have a form of ongoing investigation or another referral done, whether that was for more blood testing or referring on to allied health professionals such as our dietitians. 64 cases had a relevant past medical history. So for example, a child who had been referred for a suspected food allergy with a background of eczema. So this sort of suggests to us that there is this children who are perhaps slightly more complex do need specialist support. A quick overview of referral trend by practice locally. So the top 6 practices from our 100 cases accounted for 52% of the referrals. Although it's important to mention, we can't look too much into this, and we didn't when we presented it locally because it was from 100 cases, which is a very small proportion of the total referrals, and it was only from about a 2-month period of time. So the main bulk of our data, a total of 35 conditions were identified from all of the referrals, and the top 5 conditions, which were food allergy and intolerance, faltering growth, abdominal pain, constipation, and headache, accounted for 36% of all of the referrals. Of these, 69% had a relevant past medical history, and 83% were offered a follow-up in the paediatric department. So as a gross assessment, we can sort of suggest that is quite a justified rate of referral. Just a quick summary and overview of these conditions. So we can see again, so the median age is sort of specific to the nature of the condition for which they were referred. Majority had some sort of relevant past medical history, and actually majority, if not all, were offered a follow-up appointment. So we'll look into each condition to a bit more detail. So what we wanted to highlight here is the prior investigations or interventions that had been done before they were referred. So for food allergy and intolerance, we can see that they had tried different medication or some sort of specialized milk, And what I've highlighted here in bold is the agreement between the primary referral reason, so the reason that the GP had referred, and the secondary impression after they had been reviewed in the paediatric outpatient appointment. You can see here what we've done in this chart is we've tried to show any common actions prior to referral. So in this case, that was antihistamines, Gaviscon and ranitidine. But importantly, you can see that more than half had been referred without initiating any form of management. For faltering growth, again, you can see the sort of the wide range of different interventions before they were referred, and there was a 100% agreement between the referral reason and the secondary impression. And there were no common actions prior to referral, and 43% had been referred without initiating any form of management. So this again suggests that we do need to perhaps focus on faltering growth as something that needs more intervention with help of managing this in primary care and sort of guidance for them of what they can do beforehand. Abdominal pain, again, a very wide range of different investigations from blood tests, imaging and medication, and a 100% agreement between the referral reason and secondary impression. And the common actions included requesting a sort of a baseline set of blood tests, abdominal ultrasound and fecal calprotectin, and all of them had been referred after some sort of management was initiated. Next, we've got constipation. So again, as you'd expect, a different combination of laxatives, and in some cases they had been referred to constipation clinic or had been referred for health visitor reviews, and 6 out of 7 cases had an agreement between the referral reason and the secondary impression. And as expected, the most common action prior to referral for laxatives, but quite interestingly, in one case, they had been referred without initiating any management. Lastly, we have headache. So again, quite a wide variety of interventions from blood tests to imaging to ophthalmology review. And in one case, they had tried analgesia, and there was a 100% agreement between the referral reason and secondary impression. So the common actions, as mentioned, were blood tests and ophthalmic review. And in one case, they had been referred without initiating any form of management. So in conclusion, our top 5 conditions accounted for 36% of all of our referrals, which is quite a large chunk. 83% of these were offered a follow-up appointment, again, justifying sort of a justified rate of referral. 69% had a relevant past medical history, so suggesting these were slightly more complex backgrounds. And what we wanted to build on is, and what I've tried to point out, is that there are already some common actions that are in place between different practitioners in terms of what they're doing before that they refer. So our next steps, which we wanted to do, was to collaborate with the local CCG for any possible future interventions and work with our primary care colleagues to create some sort of guideline or pathway to help manage these top 5 conditions at a primary care level, because ultimately we do want to implement a safe way for these children to be managed at primary care for common conditions for which both our GP colleagues and as paediatricians we are sort of happy with. Just like to point out, within Milton Keynes Hospital, there is also a similar project going on between the local CCG and a paediatric department for acute paediatrics. And Birmingham Children's have actually already done quite a similar project, and they have created guidelines for their top 20 conditions for the management in primary care. And this is something that we sort of aim to build on as well. These are our references, and thank you for listening. Any questions?
Perfect. That was really, really insightful and a great presentation. So I think one of your colleagues has been answering questions in the chat as we've been going, which has been hugely helpful. So we're not going to re-ask you those questions, but we can signpost people to the chat to answer any of those specific things. I guess one of the points that we were thinking about would be paediatric or sort of outreach clinics to GP surgeries. I know that happens in a number of different places. Was that something that happens in your area, or is that?
Sorry, can you repeat the question? My sound just stopped.
No problem. So one of the things we were discussing here was paediatric outreach clinics to GP surgeries. So where paediatricians go and do a clinic within a GP surgery. Is that something that you have in your area, or is that something that it was being discussed?
So that's not something that has been discussed, and as far as I'm aware, that's not something that we have in place at the moment. So I don't think, but that is definitely something worth considering but I don't think that's something that we do at the moment, no.
Okay, perfect. And I think something that's in the chat, but something that would certainly, I think, would interest a lot of people would be sort of common referral pathways for these common conditions that you spoke about. So there's a few conditions that account for over a third of the presentations to secondary care. I don't know where we're at with, or where you're at with sort of the production of those referral pathways. And it's sort of been alluded to in the chat, but I don't know whether you've got any more specific information on that.
So we've presented this to our local CCG, and from the conversation that we had there, we were actually interestingly looking at more sort of, rather than focusing so much on the guidelines, it was trying to extend the scope of sort of health visitors and more constipation clinics. So you can see we do want to streamline the interventions that are already happening, but actually in majority of the cases that requires allied health professionals. So that's sort of what we're more focusing on at the moment. So extending, as I mentioned, clinics within practices for faltering growth, for example, or health visitors involvement. So that's sort of what we're focusing more so at the moment.
Perfect. And so as a last question, so Nico's asked about the accessibility of blood tests, but I guess we could extend that to the accessibility of lots of different types of investigation in primary care. Was there a big variation for different GP surgeries and being able to access those tests, or was that sort of not something you were able to look into?
So we did, I could see what they had requested actually, and in majority of the cases, so obviously we've got our routine sort of baseline bloods, and there didn't seem to be any issues requesting the sort of more specialist blood tests, but that was at that point, they had already referred the child onwards to the outpatient clinic. So once those results were available, they were then reviewed by the paediatrician in clinic. There wasn't a problem with accessing those.
Perfect. Well, thank you very much for that presentation. So